Hi, everyone. Welcome to part 2 of a comprehensive review of dermatopathology. In the next 6 episodes, we're going to cover neoplastic processes as we've just finished inflammatory processes. And today we're going to begin with epidermal tumors. So as an overview, what we're going to cover in the next few sections is tumors of the epidermis, tumors of cutaneous appendages, and then we're going to cover pigmented lesions, proliferations of fibrous tissue, muscle, fat, and bone, neural, neuroendocrine, vascular, metastases, non-lymphoid infiltrates, and then lymphoma and leukemia. And then you'll be done and you'll have had an introduction to pretty much every topic of your curriculum. So to begin, epidermal tumors, this is going to include not only true neoplasms, but also just proliferations and congenital anomalies, etc. So an epidermal nevis is a developmental malformation of the epidermis. Usually what you see is hyperkeratosis and papillomatosis, kind of like what you might see in a seborrheic keratosis or even a warty type change. Some variants can have these disorders of maturation, epidermal maturation, such as epidermolytic hyperkeratosis, acantholytic dyskeratosis. You can have verrucous changes. You can have porokeratosis, coronoid lamella basically growing in these. So this is a classic example of an epidermal nevus. And basically you have papillomatosis or acanthosis of the epidermis, sort of shaped like a seb, a little bit of hyperkeratosis. And often you'll have a straight bottom, which in this shade you can't really appreciate, but without a clinical history, if this is an adult, it could be very difficult to distinguish from a seborrheic keratosis. If it's a 5-year-old, your best bet is epidermal nevus. And here you can see a little bit of pityrosporum yeast in the surface because it's probably, somewhere in a seborrheic distribution. But other than that, you just see proliferation of normal epidermal cells. A nevus sebaceous or Yaddison I put in this section is not technically an epidermal tumor. It's more known as an organoid nevus because it's a proliferation of not just the epidermis, but the adnexal structures as well. But similarly, on top in the epidermis, you're going to see this papillation or this acanthosis. You're going to see immature follicles with prominent sebaceous glands, which will expand after puberty. And then your apocrine glands will be very dilated. Within this, you can develop additional little tumors, syringocystatinoma papilliferum, trichoblastomas, tricholemomas. In the past, it was reported that you could have basal cell carcinomas, which I have seen before, but they're rare. They're usually actually trichoblastomas that may have been misdiagnosed in the past. So here you can see from side to side, this is normal epidermis, and here you become very acanthotic, and that is your epidermal nevus component of this organoid nevus, and then it goes back to normal. And here you see these immature abortive little hair follicles, and you see down here below them, you do not have terminal hairs going into the fat as you do on the side. This is why these lesions are bald. They do not have hair growing in them because although they look like they have follicular structures, they are not producing hair shafts. And then you can appreciate also that you have very dilated apocrine glands below. So this is why it's called an organoid nevus, because different structures are kind of immature and aberrantly differentiated here. Here's an up close. See, again, it's just this non-specific papillomatosis or acanthosis of the epidermis, and then dilated sebaceous lobule. It kind of inserts right into the epidermis, which we know is not where they're supposed to insert. They're supposed to insert into the kind of isthmic area of the hair follicle, and then you have dilated apocrine glands below. Here's a better look at them. You have your little eccrine glands with the 2 layers of cuboidal epithelium. They're a little dilated here, but then most of these are the apocrine glands that are very dilated. Here's another look at a nevus sebaceous. In this particular one, the epidermal changes are not as obvious, though the sebaceous lobules are large and are inserting straight into the epidermis, as in the other case. Here your apocrine glands are not extremely dilated, so kind of these things sort of exist on a spectrum. Here's an up-close picture. A Becker's nevus is also similar. On top, it looks just like an epidermal nevus. You may or may not have a little bit of hyperpigmentation in the basilar layer of the epidermis, making it really look kind of like a seb. And then you may have hypertrophy and increased number of smooth muscle bundles. So it's kind of like a smooth muscle hamartoma that's not associated with hair follicles, which you would see with, say, a piloerector muscle that was supposed to be there. So Becker's nevus on top, kind of nonspecific, acanthosis and hyperpigmentation. If you give us a shave of this, you may get, you know, remember that differential we gave, you may get acanthosis nigricans, you may get confluent reticulated papillomatosis, you may get early seborrheic keratosis. But if you gave a clinical description, you know, brown patch on the right upper back of a person, then you might get a Becker's nevus in your differential as well. But here is where, if you give a punch, we may see a feature that's more definitive. And here you have smooth muscle bundles. This could be a piloerector muscle, but then you have one here, 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 all these little smooth muscle bundles. Not in a concentration dense enough to be a leiomyoma, but too many to be normal, so more hamartomatous change, okay? So here's up close the epidermal changes, nonspecific, acanthotic, a little hyperpigmented. Here's your smooth muscle bundles. See your little clear glycogen snacks that are telling you these are smooth muscle. All right, another sort of epidermal nevus is this inflammatory linear verrucous epidermal nevus. And when I think of this, I think of something that looks like psoriasis, but it's not quite, and it's tufted. So what do we mean by that? We mean that you have alternating ortho and para, because you have alternating areas in this thickened epidermis that are kind of normal and non-psoriasiform looking, and then the parakeratotic areas that look like psoriasis. So from far away, you can see that you have very regular acanthosis, like you'd expect in psoriasis. And here where you have parakeratosis, you've lost your granular layer, which is why you don't have this blue hue, and you'll have neutrophils in the cornified layer. So and look, you even have dilated blood vessels in the thin papillary plates. So it looks really close to psoriasis. And then you have a tuft here of pretty normal looking skin. It is acanthotic, but it's orthokeratotic, meaning no scale. You have a granular layer, and it otherwise doesn't look, you know, as regularly acanthotic as the psoriasis area. And then you transition again over here back to this area that looks like psoriasis. So this is what we mean by tufted. Okay, these are like your cutoffs that you can see. Here's a cutoff. See, you've lost your granular layer. Here you have a thick granular layer. Here you have neutrophils in the cornified layer. Remember, from the first section, we talked about how neutrophils in the cornified layer are sort of a defining feature of psoriasis. Here's an area that's not quite consistent with psoriasis. You have a bundle of bacteria in your cornified layer, and we know that psoriasis is not usually impetiginized based on that Th1 inflammatory pathway. However, this is not exactly psoriasis. So often people ask, well, what's the difference between ILVEN and linear psoriasis? Well, these are the subtle differences. Linear psoriasis won't have this tufted pattern, and you should look more consistently like psoriasis. Here's another example of ILVEN. You have this area that looks, for all intents and purposes, exactly like psoriasis, loss of granular layer, neutrophils in the dry cornified layer. And then you have this area where you have a granular layer, no neutrophils. And then you skip back to an inflammatory area where you have the neutrophils and the parakeratosis. Okay, those are your little cutoffs. Here's the up close, right? Where you cut off right here. And you've got the psoriasis and the not psoriasis look. Okay, so acanthomas, what are acanthomas? Well, they're things that are overgrowths of the epidermis, but not exactly a tumor per se. So an epidermolytic acanthoma is basically a overgrowth of the epidermis, kind of a sebi warty growth that has the epidermolytic hyperkeratosis in it. So that you see this shape, it's very warty looking, your papillomatosis, you've got this inward curving of your reedy ridges that looks warty, and then you have the epidermolytic hyperkeratosis changes. I mean, there is debate in the literature about whether these are truly warts. For the most part, you do not PCR HPV virus out of these, but when I see them, like say in the genitalia, and there's like 1 or 2 reports that there have been HPV, sometimes I offer to check if people want, but for the most part, we do not consider these true warts. And this is not true coilocytic change. This is acantholytic with this kind of very, very granular layer, and this is known as epidermolytic hyperkeratosis. If you see this diffusely on a patient, these are the patients that were formerly known as bullous CIE, the congenital ichthyosiform erythroderma, and now it has some different ichthyotic name that I can't remember. Here it is up close, acantholysis. It's epidermolytic, that's referring to this acantholysis. And then it's hyperkeratotic, but they don't really mention so much this prominent granular layer that looks like it's exploding, but that's also another prominent feature. A warty disc keratoma looks kind of similar. So remember, acantholytic disc keratosis we talked about in the context of Grover's disease and Darier's disease. But in this case, when you have a warty shape, a very cup-shaped endophytic lesion, and then you have your corons, cograins, this is called a warty disc keratoma. So here you have the papillated surface, you have this endophytic kind of cup-shaped lesion, and then you can see very clearly that you have all of this acantholysis, that's that pemphigus looking blistering, but then you have all of this, you know, keratin in the middle. So we're gonna go up close, and if you look, here's your acantholysis, that's on the lower portions of the epidermis, suprabasilar, right? And then here you've got your corons and your grains, which are your atypical parakeratotic cells that come off your atypical dismaturation cells. So in this instance, your epidermis is not maturing properly toward the death into cornified layer. And so you have these funny little cells, acantholysis, coron, and grain. So here in that area with a lot of the papillation, you see a lot of the acantholysis here, and then you may or may not see a lot of the disc keratotic cells, but you can tell that they're atypical because your grains are so atypical, right? These are not the shape of normal parakeratotic cells. They're extra round, the nuclei are large, etc. I'm not going to belabor seborrheic keratosis, but again, it's acanthosis of the epidermis. You might see some horn cysts. Macular seborrheic keratoses, they evolve from solar lenigos. So first you have your little dirty socks, and then as those little sock feet grow longer and reticulate, you become a macular seb. So remember, they live on a continuum. If they get very irritated, you can have squamous eddies, and then you can have clonal seborrheic keratoses, which sometimes can be hard to distinguish from squam in situ. So this is a classic seborrheic keratosis. You have these anastomosing, acanthotic aggregates of kind of normal epidermal cells. They, you know, produce keratin just the way they produce keratin on the surface. So you'll have these horn cysts sometimes, not always. See, this is an early seb where you just have acanthosis, but you don't have horn cysts. So this is another look for a seb. This is the look that you might mistaken for an epidermal nevis, etc. Here's another type of seb. I mean, this kind of looks also like what we might call a stucco keratosis, but you might have a more warty surface and flat bottom with the hyperkeratosis. And here's another more classic look for a seb with your horn cysts. This is the kind that's the reticulated macular seborrheic keratosis, where you started with these like elongated dirty sock feet from a solar lenigo that got longer and longer and started anastomosing into this macular seborrheic keratosis. Beware of the flat bottom. Remember, if you have a very, very, very flat bottom to what otherwise looks like it could be a seborrheic keratosis, think about epidermal nevi, but also think about looking in your dermis. If you have fibrosis, that means thickened collagen with increased fibroblast beneath a flat bottom, that could be the sign that you're on top of a dermatofibroma, because epidermal induction will also look like this. Okay, so if you have papillated epidermal hyperplasia, then you have the differential that we've sort of been alluding to. Seb, epidermal nevis, surface of a dermatofibroma, confluent reticulated papillomatosis, acanthosis nigricans, and even maybe lichen simplex chronicus, which we didn't really talk about much. So then there's this term melanoacanthoma. What is a melanoacanthoma? Well, this looks like a seborrheic keratosis, but it is populated by these dendritic pigmented melanocytes that exist throughout the lesion. So this particular one is not exactly a melanoacanthoma because it's atypical. So pigmented AKs, pigmented basal cells, they can all have this colonization of these benign dendritic melanocytes through them. So I just use this as an example because I have it, but you see there's pigment in here, and the way the pigment gets in is this population of melanocytes. This, in fact, is actually a squamous cell carcinoma, and it's pigmented. I have an image here. This is another squamous cell carcinoma, and when you do a melan-A immunostain to look at whether this is just melanin, heavy groups of melanin, or if they're truly melanocytes, here you can see that there are these very uniform dendritic, meaning they have little leg processes coming out of them as opposed to being a very round cell. Melanocytes kind of evenly distributed throughout. So that would be a pigmented squame, but if this was the shape of a benign seborrheic keratosis and it had this, then that's what we call a melanoacamphoma, okay? These are those melanocytes up close. These are their little dendritic processes, okay? A pale cell acamphoma basically is an acamphoma where these cells have extra glycogen and makes them really pale, and they're very well demarcated. They otherwise look like psoriasis, which I'm not sure if people are aware of. You lose your granular layer, and you always inevitably have neutrophils that you can identify in the cornified layer, in addition to this psoriasiform epidermal hyperplasia. But what you might just notice that they're really pale and there's a sharp cutoff, which is fine, okay? So here's your sharp cutoff, pale cells filled with glycogen, loss of granular layer. Up close, here are your little neutrophils. You see your little multi-lobed cells, dilated vessels in your papillary plates. Okay, so those are our benign entities. Let's move on to tumors. So there's not that many tumors we deal with. We have pre-malignant ones, actinic keratosis, intraepidermal carcinoma, so that's squamous situ / Bowen's, bohenoid papulosis, or VIN, etc., depending on what field you practice in. We have different carcinomas: basal cell carcinoma, squamous cell carcinoma, verrucous carcinoma. That, of course, is not an exhaustive list, but for your purposes, that's sufficient. And then miscellaneous, we'll put keratoacamphoma in there because it's sort of a messy topic. So actinic keratosis. Actinic keratosis is atypia that can become squame. Now, only 1 to 5% over 5 years becomes squamous cell carcinoma. But what you first see is atypia of your keratinocytes in the lower level of the epidermis. And by atypical, they usually become larger with more pink cytoplasm. Their nuclei are larger, and they often overlap each other. They don't respect each other's space like the normal epidermis should, where the basal cells line up next to each other. You'll see alternating ortho and parakeratosis, which you'll see corresponds with the sparing of the adnexal structures of these atypical cells. So here you have orthokeratosis arising above this sweat gland, parakeratosis, which you see as solid pink and nuclei, back to orthokeratosis, parakeratosis, orthokeratosis, para-ortho. See, and you'll see those might be over a follicle or over a sweat gland. And this, sometimes people have called this the flag sign, the red, white, and blue. I don't really see the white. Sometimes these colors don't work for me, but pink and blue and pink and blue and pink and blue, as my fellowship director used to like to say. And you can clearly see where these cells, even from low power, are atypical. They're much bigger and pinker here than they are over the adnexal structure, where they're much tighter, smaller together, and more blue. Right? Can everyone appreciate that? Going up close, here are your more normal epidermal cells, and here they are when they're bigger and pinker. You see your nuclei are overlapping, and when they're atypical, they give rise to parakeratosis. When they're more normal, they give rise to orthokeratosis. So I always ask my residents, why does it skip? And the reason that it skips is because your hair follicles from the bulge, right, have stem cells that replenish the epidermis. So it's constantly pumping out new cells to try to overcome this atypia. And you even probably have stem cells in your sweat glands also. So they're all sort of bastions of resistance against this change towards atypia, which is part of why such a small percentage of actinic keratoses become squamous cell carcinoma, because you have inflammation that tries to get rid of these atypical cells. You have this constant replenishing effect as your body tries to resolve this problem. Okay, here's another look. You can see this sharp cutoff in the epidermis between the smaller keratinocytes and the bigger, more atypical keratinocytes. Here's another cutoff line. Here you have orthokeratosis, here you have parakeratosis. Here again, you can see a sharp cutoff, sharp cutoff, sharp cutoff. It even is going down the adnexal structure a little bit. But as long as it's skipping and it's not totally full thickness, you're still actinic keratosis. Okay, sometimes they can be a little acantholytic, and now you've got a little white space between the atypical cells. You see how they're all jumbled together and disorganized versus your normal cells, which line up, you know, like your palisaded basal layer. So actinic keratosis. So squamous cell carcinoma in situ, this is when in the epidermis you have full thickness atypia of the keratinocytes. Sometimes it's confluent in full thickness, sometimes it's pagetoid, meaning all the cells are normal and then you just have a few abnormal cells skipping up toward the top. That still counts as full thickness. Bowen's I do not use synonymously with squamous cell carcinoma in situ. A lot of people do use it synonymously, but originally the diagnosis was described in sun-protected skin, probably has more of an HPV-related origin, and so those are what is supposed to be referred to as Bowen's, and it has sort of a slightly different histopathologic look than other squamous cell carcinomas. So I don't use them synonymously. I just call everything a squamous cell carcinoma in situ, and then I'm never wrong. Erythroplasia of Carat, that's the squamous cell carcinoma in situ of the penis, and then Bowennoid papulosis, when we're sort of implying that those high-risk HPV types of condyloma are associated with change towards squamous cell carcinoma. So here, again, we have that warty shape. You have that papillomatosis. You see your inward curving rete. They're holding hands. This is your wart shape. And in this wart shape, you can see that your atypia has become full thickness. Another thing I like to point out, because sometimes in an AK, you can have pink go all the way through to the top. How do you know it's atypical enough to go from AK to squam in situ? Well, I call it a loss of polarity. In the epidermis, you can usually tell if I cut a section out, what's the top and what's the bottom. If I gave you a little section and I turned this sideways, you would usually know it's sideways because the granular layer is usually on top. These kind of diamond-shaped spinous cells are usually in the middle, and this tall columnar-shaped cells are usually the basal layer. But now, when you got squam in situ, often if I took this section and I turned it sideways or upside down, you would have no idea which way is up and which way is down because you've completely lost polarity. That's one of the signs for me that you've crossed over into squam in situ. Not to mention the atypia here is significantly worse. So we know that a lot of squams are derived from HPV because patients who are transplant patients or immunocompromised, they suddenly go from a population that mostly has basal cells to a population that mostly has squamous cells. And that's because the immunosuppression sort of lets this HPV-driven process run wild. And so, you know, these ones that are shaped in a more warty shape probably are HPV-derived squamous cell carcinomas. Here is a sort of different look. These cells are less pink, they're very blue. Why are they very blue? Because the nuclei here are very large. When you have very large nuclei and very little cytoplasm, visually, that cumulative effect for your eyes makes it look very blue. So if you look down, you're like, whoa, that epidermis looks very blue. Make sure you go in and look and see if you see squamous cell carcinoma in situ. You see it here again, you've completely lost polarity of your epidermis. You would not be able to tell which way is up and which way is down. This is an example of a more pagetoid squamous cell carcinoma in situ. You have these individual cells skipping, and you can see your background. You see your little grid of desmosomes, that sort of a normal pattern, and then these atypical cells kind of skipping around inside there. This is more of that Bowen's pattern where you see your perfect basal layer, and then all of your atypia is above it. And that sort of tells us this is a different process, because remember, actinic keratoses, which are really sun damage derived, those start with atypia on the basal layer. But this one, the basal layer seems to be spared, giving you this eyeliner look, and then all of your atypia is above it. So perhaps this comes up and around from an adnexal structure. We're not really positive. Maybe it has to do with a little bit of an HPV related process, but it just looks a little bit different, but still a squamous cell carcinoma in situ. Here's another one. Now you've got really large bulbous aggregates. Some people, because these extend down into the reticular dermis, they'll call it a squamous cell carcinoma and not just in situ, but others like to keep to this purest view where if it all connects to the top, it's still squamous cell carcinoma in situ. But as you can see, they can be very thick. And this one's also very pale. So you can have very pale cells, just like we can have pale cell acanthoma in the epidermis, we can have pale squamous cell carcinomas. So this is just a reminder of how things look. This is normal. You have your basal layer, everything lines up, your spinous layer, your granular layer, making nice orthokeratotic cornified cells. This is what happens when they become atypical. First of all, look at all that solar elastosis. So this person's very sun damaged. Now your cells are big and pink. They skip the adnexal structures. You're making parakeratosis where it's abnormal. And here the abnormal is taken over. And look how big these nuclei are compared to these. Look how you can see that grid work of your desmosomes because the cells all respect each other's space. And here you can see they all overlapping each other and they've taken over that pattern. Okay, moving on to squamous cell carcinoma. Now, just like squamous cell carcinoma in situs have different morphology, squamous cell carcinomas have very different morphologies. Their definition is when atypical keratinocytes invade into the dermis, and I use it for when they detach from the epidermis, though others will use when it's just thick enough to be down in the reticular dermis. It depends on where you biopsy. If you have a large nodule and you biopsy off on the side, you may not see this tumor connect to the epidermis because sometimes they only connect on the center top of the lesion. And squamous cell carcinomas do not always go through the process of becoming full thickness atypia before they drop down. They can often just drop down. So on a superficial biopsy, it can often be difficult to make an accurate diagnosis. So in this case, you can see that this squamous cell carcinoma, look at all these atypical keratinocytes. In the dermis, it's not connecting here to the epidermis. And if you gave me a superficial shave, you might get nothing, hardly even an AK up here. Okay, so be careful with superficial shaves of squamous cell carcinoma. Here's another squamous cell carcinoma. Here you have your atypical keratinocytes, right? Your nuclei are too big, your cytoplasm is too much, and it's down in the dermis. And look, you don't have to go up through squamous cell carcinoma in situ to come down. Often you can be atypical here and then just drop down. That's kind of the normal pattern for sun-induced squamous cell carcinomas. Here, you're going from exactly what I just said. The atypia is on the bottom layer, kind of like AK, and then it's dropping. And you can see in here these aggregates of atypical keratinocytes throughout the dermis. Here's an up close view. See how you're not going through squam in situ before you're dropping down. And these are atypical keratinocytes, which you can tell because they're pink, they're making little keratin bits, and they have desmosomes for the most part holding them together. Now, that's a well-differentiated squamous cell carcinoma. You can easily tell these are keratinocytes. Things can start to get very blue, in which case you're heading towards a more moderately differentiated squamous cell carcinoma. Those Bowen's type cells that we saw with those big nuclei, if those lesions ever invade the dermis, they are kind of the look of moderate differentiation. Here you can sort of still see that these are epithelial cells because they still hold together like sheets of epithelium, even though they're very blue and very ugly. Look at this one wrapping around a nerve. These are more aggressive, but they're not as bad as these. These cells don't even hold together. You can have no idea what these are. Are these melanocytes? Are these squame? Are they angiosarcoma? You have to stain to know, and that's when you've hit poorly differentiated, okay? So those are squamous cell carcinomas. Basal cell carcinomas are derived from the hair follicle. We used to think a long time ago that they were from the basal layer of the epithelium, but that doesn't really make sense because the basal layer is not that blue. What is blue is the hair follicle, like the matrical portion of the hair follicle. These probably come from the stem cells in the bulge, which give rise to the matrical portion. But what's most important is that they palisade on the edges and they have this fibromyxoid stroma. And because it's very myxoid, sometimes you can see clefting from the stroma. So here's your palisade, your follicular blue structure, and then you have this hazy gray layer around it, which you can cleft from. Here's, if you can appreciate, you see that gray layer around the blue? Sometimes you can have very blue looking actinic keratoses, where you can have little hair follicles. And so this little layer of gray fibromyxoid stroma really helps you tell that you have a basal cell carcinoma. And this is a superficial multifocal type basal cell. Here's an up close. You see the myxoid part makes it very loose because of the mucin, right? And because of that mucin being loose, you can cleft in as an artifact basically during processing. Here's an infiltrative basal cell carcinoma. Now you have this change in the collagen that makes these things become these pointy little edges that dive deeper. This is going to be more aggressive than a nodular basal cell carcinoma that's round. You see that very gray background? That's all of your fibromyxoid stroma. Here's a little bit more. You see that little myxoid rim around there? Here's another infiltrative one where now you've got these angulated nests coming down. This is a fibroepithelioma of Pincus. These were debatable in the past whether it should be put in the basal cell carcinoma category or kind of a follicular adnexal benign neoplasm category. And just based on clinical lines, it was decided to be put in the basal cell carcinoma category, but this sort of rides the middle. And these are sort of papular, sometimes taggy lesions on the back usually, but you have these elongated areas of these basaloid cells and they bear the same stroma as basal cell carcinoma. So you'll see this fibromyxoid stroma surrounding it. And we're going to see later in the adnexal neoplasm, when you're talking about follicular adnexal neoplasm, the stroma is different. So I think clinically and histopathologically, that's where the line is drawn. Here you see the blue layer around, the clefting. Here's a feature that you often see in basal cell carcinomas. If there is damage to the epidermis above, you can get this squamatization of your basal cell. That means they start to look pink and they're making keratin and it looks like squamous cell carcinoma often, but then towards the bottom you'll round out to be basal cell carcinoma. Here's an up close of what looks like squamous cell carcinoma. This has mistakenly been called basosquamous carcinoma. These are not basosquamous carcinomas. Basosquamous carcinoma is when the lesion looks like a squame and a basal at the bottom of the lesion, not at the top where it's irritated, because you'll see this irritation change. See, here it's a little irritated and you're getting a little squamatization on top. You see this in almost any basal cell because they're often ulcerated, okay? Here, on the other hand, is a basal cell with this very significant squamatization. This is in the reticular dermis where you've got this basaloid edge and this very squamey look in the middle. That's a true basosquamous carcinoma, not the irritated ones with the squamey look on top. Keratoacanthoma is a different type of lesion in that clinically they can regress. So sometimes in the process before they're regressing, there is a lot of overlap between a keratoacanthoma and a squamous cell carcinoma, and it can be unfair to try to draw that line. The keratinocytes have a glassy pink cytoplasm. There shouldn't be significant atypia. Remember we saw in the Bowen's kind of squame or that moderately differentiated squame where you had those huge nuclei and they're really atypical. These should be glassy and pink and relatively uniform. There shouldn't be significant atypia. So here you see this cup-shaped lesion and it's very pink because there's a lot of cytoplasm. And when you go in, these pink glassy cells have about the amount of atypia you might see in either a really well-differentiated squame, or sometimes you can even see it in pseudocarcinomatous changes that we see with those infections that we talked about in an earlier section. But you have a lot of cytoplasm here and it's hard to distinguish the cell borders. Here's a lesion that's older. That was an early Ka. As the lesion gets older and starts regressing, those epidermal changes start to shrivel in. Once they start to shrivel in, you see only orthokeratotic change. Here you see these changes of atypia are very minor, almost less than you might see in an actinic keratosis, but they're still big and glassy pink. This is when the lesion is fully regressing. You see this fibrosis all the way around. It's because lichenoid inflammation has gone and is eating it away and shrinking it inward. When it starts shrinking inward, look at your epithelium now. Now you've completely lost any of that glassy pink atypia. All of this has got a granular layer. You stop making parakeratosis. Now you're making orthokeratosis. These lesions are just called straight up KAs, whereas the stages before, some might call it a squame KA type, or a KA can't rule out squame, because there's a lot of overlap. So compare the atypia. This is reactive, glassy pink, could be just KA, and this is true atypia, where you have these atypical nuclei. Here's another regressing KA. This one, all you have left is the cup shape. And now you see the fibrosis underneath that looks like a scar. And when you go up close, your epidermis is very thin now. It looks completely normal, like a normal epidermis. This parakeratosis is like a sign of old atypia that used to be there. But now the new cornified cells are not parakeratotic. And this is a completely regressing KA. And that is all.